Good afternoon. Let me present to you some facts of this case. We have a 62-year-old male with ankylosing spondylitis and was not compliant to his medications. He was brought in because of pain at the right lower extremity, which he sustained after a fall a year prior to admission. This injury has caused him to become bedridden and in constant pain, most especially upon movement of his affected extremity. But this was relieved by partially relieved by as-needed doses of etoricoxib. He was advised surgery here in Metro Manila because of the lack of facilities in his area. But his sister insisted that he be brought to our institution, hopefully to manage him. So he was brought to Bacolod City and eventually to us, where he was scheduled for elective total hip arthroplasty. He was also hypertensive. He had a stroke in 2011 and with a right-sided residual weakness. And he also has bilateral rheumatoid arthritis. This is the actual picture of the patient, and we see here an edentulous patient with an adequate mouth opening, however, is a Malampati class 4. He has been diagnosed with ankylosing spondylitis, and what is important is a cervical area range of motion. And that we see here, he has a fixed flexion of the spine at 30 degrees. No extension, no rotation. Other findings were that he had this kyphotic deformity of the thoracic spine. Although bedridden, he had no lesions on his back. His intervertebral spaces could not be palpated. Because of the fracture, he had leg length discrepancy, and because of the arthritis, he had bilateral contractures of the hips. Now, these are his blood examinations, and they were within normal limits. This just shows us the intertrochanteric fracture. What I wanted to show in this picture here is, although not clearly seen because of the view of the x-ray, is a spur formation at the lateral margins of the thoracic vertebrae, and this is very much consistent with the diagnosis of ankylosing spondylitis. So much so is the next picture. This gives us a picture of the classic bamboo spine of ankylosing spondylitis. Seen in this patient's radiograph, we see here fusion from L1 to L5. This just shows us the arthritic changes, which is expected because of the arthritis. Now, the following anesthetic dilemmas are given. The management of the airway, first and foremost. We have a difficult airway patient. We have a fixed flex spine deformity, and so do we intubate this patient using conventional laryngoscopy? If we intubate this patient, we have a fixed flex spine. There is cervical immobility. And with that, there is inadequate alignment of the oral, tracheal, and pharyngeal axis, therefore causing difficulty in viewing the glottis. At the same time, a little hyperextension would bring about risk of cervical fracture or vertebrovascular insufficiency in this patient. Video laryngoscopy has been shown to be effective. However, this is only for those with experience in operating such a device. LMA, we have a patient who has a fixed flex cervical spine. And studies have shown LMA could be done, but in this particular patient, there comes a risk that when we insert the LMA, it might kink and it might not rest on the trachea, and if that happens, we lose the airway. So for a patient with anticipated difficult airway from the very beginning, the technique of choice is still awake fiber optic intubation. Positioning for this patient is a challenge, whether it be for general anesthesia or regional anesthesia, because of these following patient conditions. Now, the choice to have general anesthesia, as always, it's given for patients with ankylosing spondylitis for hip surgery, but studies have shown that these patients have a high risk of perioperative stroke with an odds ratio of 3.15. Now, this patient has much more because he had a stroke already in 2011. Now, to do central neuroaxial anesthesia in this patient is usually done for hip surgeries, but we will subject this patient to so much discomfort because of the pain and the rheumatoid arthritis. At the same time, because of the technical difficulty in doing this anesthesia to the patient, we have this increased risk of complications, such as perhaps an inadvertent intraosseous injection of the local anesthetic, which might cause seizure in the patient, as reported in literatures. Now, what is the alternative technique? Studies have shown us that combined lumbar and sacral plexus block can give surgical anesthesia to the hips, whether it be alone, in combination with other blocks, with sedation, or with general anesthesia. But the patient still has to be positioned to do this block, so the following 3 medications were given. Now, to give the surgical anesthesia to the hip, you have to block L1 to L2 to S1, which innervates the hip, as well as the skin from which the incision is to be made. So these are blocked by the lumbosacral plexus block. So to do the lumbar sacral plexus block, you put the patient in a lateral decubitus position, you identify the landmarks, and at the same time, you put the probe sagittally around L4, and you see this hyperechoic structure as pointed by the arrows, that is the lumbar plexus, and the confirmation of needle placement under dual guidance is seen as contraction of the quadratus muscle. The sacral plexus is still done on a lateral decubitus position. And these are the landmarks. In scanning along that area, you would see this hyperechoic structure as pointed by the arrows. And still under dual guidance, you would either see plantar flexion or dorsiflexion of the foot. For this case, we did see plantar flexion of the foot. Now, why did we do fiber optic intubation? The patient, during the conduct of the block, had pain on the contralateral hip. It was so discomforting to the patient such that during surgery, he will still be on a lateral decubitus position. So we opted to do awake fiber optic intubation. We decreased the secretions using glycopyrrolate, and a spray-as-you-go technique using lidocaine 2% was used to anesthetize the airway. The visualization of the tracheal rings, we inserted the tube, and confirmation of tube placement was with auscultation of equal and bilateral breath sounds, as well as EtCO2 of 30. And induction of general anesthesia was done soon after with propofol. And once the eyelash reflex was gone, we gave atracurium to this patient. Sevoflurane was used to maintain the anesthesia, and this was just at 0.6 MAC all throughout the procedure with no opioids given. The EtCO2 was maintained from 35 to 45. Now, just a summary, we have this patient with ankylosing spondylitis who was hypertensive, who had a stroke, and who had rheumatoid arthritis. He was a difficult airway and had a fused spine and a pain upon movement of the extremity. So why did we choose to give this anesthesia? Because this anesthesia eliminated the complications of general anesthesia alone or neuraxial anesthesia. It has improved the hemodynamic stability of the patient intraoperatively. It has lessened his opioid requirements both intra and post-operatively. Awake fiber optic has given him comfort and better control of the airway. And because with the proper equipment and trained personnel, despite us being in the provinces, we were able to do it successfully and help the patient stand soon after recovery. Thank you very much.